Thank you very much, Mr. Chairman. Thank you very much, ladies and gentlemen, for giving me the opportunity to speak to you this morning. I'm going to present a study that's part of my overall research aims, looking at the systematic evaluation of decision-making in colorectal cancer tumor boards, the development and validation of a quality assessment tool. No disclosures from myself or my co-authors. The aim of this study was to develop a robust tool to assess the performance of the colorectal cancer tumor board meeting. A background to this: colorectal cancer is common and it kills people, and it's an area that has seen great advances in cancer care. We have had changes going from individual clinicians organizing treatments to a more team approach to this. There is a slight difference between tumor boards as described in the United States and multidisciplinary treatment care teams across the globe. However, the fundamental aims are very similar. It's a treatment planning approach where a number of doctors from different specialties come together to review and discuss the medical condition and treatment options for a particular patient. The rationale behind it is that more people, better specialty, equals better performance and better outcomes for patients. However, there are varying levels of implementation across the world, and despite it being advocated by national cancer plans across the world. We therefore set about developing a tool to assess how colorectal cancer tumor boards run and see if that has any effect on outcomes. It was a multi-phase study. The first phase was a systematic review looking for the current best evidence. The next phase was an interview study from experts that attended colorectal cancer tumor boards. The third phase was a questionnaire study, and the final phase was an observational study using the developed tool. The first phase identified no specific tools used in colorectal cancer. It identified 26 studies looking at tumor boards in colorectal cancer, but no specific methods of assessment. One of the key things that it highlighted was that there was huge variation in practice. A wider search on tumor boards across specialties, however, identified a tool that was in use in urology cancer MDTs. So we decided it's better to, rather than reinventing the wheel, to work from that. However, urology cancers and colorectal cancers are different, and using the same tool would have meant comparing apples and oranges, and therefore we took the next step of trying to validate this tool for the use in colorectal cancer. We developed a questionnaire which we gave out to 20 experts that attended colorectal cancer tumor boards. Overall, the content validity index was high, which means that they liked the tool, but they did suggest certain changes to specify this more towards colorectal cancer. The next step was the interview study, which again fed into the development of the tool, where we identified things that people would like to see assessed when looking at colorectal cancer tumor boards. The final step, following the development of the tool, which broadly was split into two categories: assessing the quality of information presented to the meeting, as well as assessing the quality of the contribution of those that were present at the meeting. And as you will see, chairs, surgeons, physicians, oncologists, specialist nurses, radiologists, histopathologists, and the coordinator. The following is a summary of the tool itself, which is split into different categories, all of which are rated on a scale of 1 to 5. And have specific anchors for the different scores. We then went ahead to see if this tool was usable in practice, and so we observed 267 patient cases over 11 colorectal cancer tumor board meetings to see whether or not we got some sensible results. A proportion of these cases were actually assessed by two different raters to see whether or not this tool was usable by different people and provided similar results. And the results of that showed that the inter-rater reliability was high, 0.7, which again means that different people using this tool would still rate similarly. One of the outcomes that we assessed was whether or not the tumor boards reached a confirmed decision, and that was the case in 258 out of the 267 cases. Further analysis of this data is presented elsewhere, but overall the absence of the treating clinician and the absence of a core member of the team were significant in determining whether or not a decision was reached. The next slide is a little bit busy. It essentially presents the results of the observations. The first column gives you the mean scores, the standard deviations, and finally the p-value represents a t-test against the scale midpoint, which was 3. To summarize, The results showed that poor quality information was presented on patient views and psychosocial issues. Now that's quite important because what the patient wants sometimes is different to what the clinician wants to do to the patient, and it's very important that we take that into consideration. And secondly, in terms of the contributions, there was quite significant differences between the contributions of various specialties. Now we all know a team works as well as its weakest link, and therefore one of the next steps is trying to address why there are differences in the contribution. To conclude then, colorectal MDT mode, which is a tool that we've developed, provides an evidence-based and user-informed approach to assessing decision-making in the management of colorectal cancer patients. However, that's not the end of it all. The aim of this all is to improve how the meetings run. And what this tool does, it allows us to quantify how tumor board meetings run. As surgeons, we like numbers, we like objective evidence. This tool provides that and gives us the potential to identify areas where we can improve our practice and therefore optimize decision-making in cancer care. Thank you very much for listening. I'm open to any questions.
It's open for discussion. How many people in the audience participate with tumor boards? So was that about half, maybe? Half, or a little bit less than half?
Can I add on to that question? May I ask how many people have visited another tumor board to observe how their tumor boards run? That's 3 in the audience. One of the things that we highlighted, particularly with the systematic review and in interview study, was that there is a huge variation in how tumor boards run. And what we hope to do with this study and ongoing studies within our group is to try and bring some sort of standardization to how tumor boards run and therefore provide some evidence as to what sort of an impact they have.
My name is Michael Lee from Hong Kong. My first exposure to tumor board was with Bill Hill's TME program at the Atkin Center. And at that stage was mainly interested in pre-op staging and histology of, say, carcinoma of rectum. Does your tumor board involve other colorectal cancer as well?
Yes. I'll answer your question in 2 stages. The Pelican Foundation that is referred to here is a foundation in the United Kingdom looking specifically at rectal cancers and the nuances of staging and treatment in this case. The tumor boards that we've assessed here, this was one tumor board that assessed both colorectal patients, colonic cancers, rectal cancers, as well as a small proportion of anal cancers. So it's a mix of different cancers. The next steps towards this study are rolling this out across different sites, and so different sites will have different proportions of the different cancers, as well as specialist sites and tertiary referral centers.
Another question back there?
Yeah, Maria Mora from Chicago, Illinois. Do you have an example of 2 questions. Do you have an example of the tool available on the slides? And second question, how can tumor boards implement this to improve further meetings?
I'm sorry, I didn't quite catch the first part of the question.
Did you have an example of the tool that you used?
Yes. If I could go back to the slides.
Pull up the slides again, please. Answer the question without the slide, please.
I mean, essentially, the tool was presented in the slides 15 and 16. It's split into 2 different categories, one looking at the quality of the information presented to the meeting, and the second looking at the quality of the contributions of various individuals. The slide after that, which showed the various scores and anchors, are the specific criteria that we use to score the tool. But if you would like, I can give you a paper copy of it or an email copy later on.
Yeah, I have a comment, if I may. Your message is clear that the answer is multidisciplinary approach to patient management. We've carried this one step further in that we have a rectal cancer patient management conference every 2nd week, and it gives us an opportunity as surgeons to interact and transfer thoughts with the pathologist, with the medical oncologist, with the radiation oncologist, and the multidisciplinary approach is certainly worth endorsing. Thank you.
Thank you very much for your comments. It's just to take that a step further. What a lot of people may not realize is the usefulness in terms of teaching and learning of the multidisciplinary tumor board. The amount of job satisfaction that people get, the amount of teaching and experience that they draw out of this is quite a lot as well.
Thank you very much.